Well, welcome to a wrap-up of the ESC 2013. It was an amazing meeting. Deepak was there, as you saw, with the coverage. We have, pages of trials and slides and everything on CardioSource, and we wanted to pick out sort of the big practice-changing trials. I think you headlined things with the SAVOR-TIMI 53 study, and also the EXAMINE trial were two of the diabetes outcomes trials. You want to summarize what was found?
Sure. So SAVOR-TIMI 53 and EXAMINE were both large diabetes cardiovascular outcome trials. SAVOR-TIMI 53 was about 3 times the sample size, but they were both designed primarily to satisfy the FDA mandate to show that new diabetes drugs aren't increasing heart attack risk. And there's some complexity and subtlety to each trial, but I think from a bottom line perspective, both drugs, which are DPP-4 inhibitors, a type of glucose-lowering agent, seem pretty safe from a ischemic standpoint.
That's terrific. Certainly questions on if there's no benefit, then what is the target, and probably lots of things will come out over the coming months.
Well, yeah, those are questions that cardiologists wondered, as it's not reducing ischemic events to use these agents. Are they actually useful? But I think we often forget about the microvascular side of the equation, where diabetic doctors, whether it's primary care or endocrinology care, need to do something when a patient shows up with a glucose that's out of control.
Yeah. There were a lot of very interesting interventional trials. The biggest, I think, was TASTE, looking at thrombus aspiration in STEMI, like 7,000 patients, not finding a benefit. I wonder what you thought of this.
So 2 points about that trial. One is it was essentially a trial nested in the large Swedish registry, so a pretty neat concept of doing a randomized trial within a registry. Lots of strengths to that approach, potentially some weaknesses as well. But what this study examined specifically was thrombus aspiration, manual thrombus aspiration using a catheter before stenting in primary PCI versus just going ahead and doing PCI without that. And the primary endpoint was mortality, and there was no significant difference between the two arms. I would caution that was just 30-day mortality. One wouldn't necessarily expect a difference that soon. The meta-analyses and even individual trials that have found a significant reduction in mortality has been with longer follow-up in the 6 to 12-month range. There were some secondary endpoints, though, that were favorably influenced, like total stent length and other practical issues that might still make it a useful technique. Also, one large ongoing trial as well, the total trial, similarly large-scale mega trial. So I'd say let's wait for the longer-term follow-up with TASTE and that other trial before saying anything too definitive.
Terrific. Okay. Well, and then another intriguing one that goes 180 degrees opposite to current guidelines, the PRAMI trial, also in STEMI,
Right.
of whether you should intervene on the other non-culprit lesions, that suggested a pretty big benefit that they had to stop early.
This is absolutely right. So first of all, it was a relatively modest-sized trial that was stopped early because of efficacy, but still have to be a little cautious when a trial is stopped early. That tends to overestimate benefit. But nonetheless, it supported a concept that, in truth, many interventionalists do believe deep down inside, that in someone that comes in with ST elevation MI, there is benefit to revascularizing the non-culprit lesions as well. Obviously, in shock, you want to do it right away. But even here, this wasn't shock. This was patients that had other 50% or more stenoses in the non-culprit artery. So, again, there's another larger trial going on this topic, the COMPLETE trial, and I'd say, perhaps wait till that comes in before totally changing things. But this does make intuitive sense, and it was how many interventionalists were practicing until the guidelines and AUC and so forth said, stop doing that.
Wow. Well, it's fascinating. We think we know stuff, and then, a class 3 in the guidelines. But I think another study, the ACCOAST trial, large 4,000, early prasugrel pre-cath didn't help and had more bleeding.
Right. So again, that's something where it's just become dogma that pre-treatment, of course, it's a benefit, but if one looks at the actual data supporting it, it's not altogether the strongest level of evidence. It's mostly observational data or post-hoc analyses from randomized clinical trials. But what ACCOAST did was prospectively examine prasugrel pre-treatment and did not find any benefit, did find a little bit of bleeding, but no actual benefit. So I think, again, we need to really give some thought about things we assume are true or may even be in the guidelines, but then the data don't actually support it.
A new novel agent, anticoagulant in the HOKUSAI VTE, that looked good, equivalence on efficacy but better safety of new 10A inhibitor edoxaban.
That's right, and the data did look really good for this novel agent. There's a big atrial fibrillation trial that's also in the works that our colleagues here in TIMI are doing, ENGAGE. So perhaps there'll be more data about this agent edoxaban and atrial fibrillation. But the DVT data look good.
Yeah, that's interesting. I don't know actually the space of how uptake of the new agents is in that thing, but there have been consistent trials with benefits, I think, in safety certainly, and very promising shift probably in practice.
Yeah, I agree. So both in the venous thromboembolism world and the AFib world, these novel anticoagulants will be pretty good.
Yeah. Final few notes. I think we saw the data on dabigatran in mechanical heart valves, and that did not look good. There's a black box warning on all of the new agents there.
Absolutely. So it might be different whether the clot's in the vein, whether it's in the left atrium, or whether it's forming on a mechanical surface.
Yeah, and I understand like pharmacokinetics in a post-op patient was part of the issue there.
Right.
So more to be sorted out. Another small trial, but looked at colchicine, had a big reduction in recurrence or persistent symptoms in first episodes of pericarditis. So it's sort of an offbeat, but it's been a couple of trials now.
Yeah, colchicine's been looking pretty good in pericarditis, previously in post-op pericarditis. So that's looking good.
And there was losartan looked good for aortic dilatation and Marfan syndrome.
That's right. Building upon some older animal data that also suggested a benefit in mice, but this is in humans, so that's good.
Yeah. So a terrific meeting. I think lots of practice changing, some unexpected findings. So all of the summaries that Deepak oversees of the trial summaries, these are on Cardiosaurus slides of many of them, and I encourage you to look over all of what we learned at ESC 2013.